Hello, it's Dmitry again. Today we'll be covering the first aid for the USMLE Step 1 textbook, the 2025 edition, for the GI chapter, Gastrointestinal. Again, I'm reading from the 2025 edition. The screen that you see behind me is the 2017 edition, so there'll be some discrepancies betwixt the two, but overall the content will be very similar. And so let's begin with the quotes. I'm going to read my quotes, and I might just see there's some differences I can see on the PDF that I want to make note of. So this is not important content, by the way, these quotes. They're just not, okay? So the quotes are, "A good set of bowels is worth more to a man than any quantity of brains." Josh Billings, okay. "Man should strive to have his intestines relaxed all the days of his life." Moses Maimonides. I'm not familiar with that Maimonides quote at all. Okay. "All right, let's not panic. I'll make the money by selling one of my livers. I can get by with one." Homer Simpson, The Simpsons. Haha, very funny. You get it? Because he thinks it's like a kidney. Wow. Okay. "The truth does not change according to our ability to stomach it emotionally." Flannery O'Connor. Okay. Now, they removed the William James quote, I think, which is life worth living? It all depends on the liver. Okay. I did the psych chapter yesterday, and they replaced the St. Augustine and Hippocrates quotes with a Michelle Obama quote and some other quote from somebody else. And I was just noticing it's kind of slowly, there's sort of a slow appeal over the years to sort of the lowest common denominator, you could say, or perhaps the person who thinks they're very intelligent or very educated or very reserved, but is in still fact not particularly intelligent. So I'm not sure if the switch over to having a Homer Simpson's quote is kind of in the same vein as that, perhaps. I'm not sure. Maybe they want to keep it a little bit less serious. Fair enough. I'm being a little bit passive aggressive, perhaps. But let's begin. Gastrointestinal embryology. And for reference, by the way, I'll be reading the first three sections today from the book. I'll be reading today the embryology, anatomy, and physiology sections, and I plan on covering the pathology and pharmacology sections later in a different video. But now on with embryology. And I have a picture of tongue development. I want to see if they covered that anywhere here. Again, there are some variations to these. So mine begins with tongue development. If I don't see anything on it, I'll just have to talk about it and just have you listen to my voice about it. Gastrointestinal embryology. Tongue development. So the back part right there is 10, cranial nerve 10. The posterior portion of the tongue is regarding the arches 3 and 4 and the cranial nerve 9. And then the anterior part of the tongue is going to be innervated by cranial nerve V3, which is just basically the third branch of I think it's mandibular branch of the trigeminal nerve, and cranial nerve 7, which is the facial nerve. And the facial nerve is doing the muscle, if I'm not mistaken, and the V3 is doing the sensation. So let me just read this out for you. The first, and also arch 1 is doing the anterior 2/3 of the tongue. So anterior 2/3 of the tongue is first arch, third and fourth arches do the posterior third, and then I think the back there is its own little cup of tea, I suppose. I'm not quite sure. But first pharyngeal arch forms the anterior 2/3 of the tongue, sensation via the cranial nerve V3, which again is the mandibular branch of the trigeminal nerve. Taste via cranial nerve 7, which is facial nerve. Third and fourth pharyngeal arches form the posterior third of the tongue, sensation and taste mainly via the cranial nerve 9, extreme posterior via cranial nerve 10. So cranial nerve 10 covers a very, very back part of it if you really want to go into it. Motor innervation is via the cranial nerve 12 to hyoglossus, retracts and depresses the tongue, genioglossus protrudes the tongue, and styloglossus draws sides of the tongue upward to create a trough for swallowing. Motor innervation is via the cranial nerve 10 to the palatoglossus, elevates the posterior tongue during swallowing. And here's a little note aside here. It says taste, 7, 9, and 10, nucleus tractus solitarius, NTS. So basically the taste is coming from the nucleus tractus solitarius, and it's going to be involving nerves 7, 9, and 10. Pain is done by cranial nerves V3, 9, and 10. And then motor is done by cranial nerves 10 and 12. And here it says the genie comes out of the lamp in style. And that's referring to the three different kinds of muscles, which is going to be the genioglossus, which protrudes the tongue, and the styloglossus, which draws the sides of the tongue upward to create a trough. We also have here the cranial nerve 10, CN10, innervates palatonglossus. They say so palatoglossus, which is innervated by cranial nerve 10. They say it's palatenglossus, is basically cranial 10 innervated. Makes sense? Now let's go into the thing that they're talking about with its congruence here, overlap. Normal gastrointestinal embryology. The foregut, esophagus to duodenum at level of pancreatic duct, and common bile duct insertion, ampulla of Vater. 4th to 6th week of development, stomach rotates 90 degrees clockwise. Left vagus becomes anteriorly positioned, and right vagus becomes posteriorly positioned. Midgut, lower duodenum to proximal 2/3 of the transverse colon. 6th week of development, physiologic herniation of midgut through the umbilical ring. Yolk sac and midgut are connected via the vitelline omphalomesentéric duct. 10th week of development, returns to abdominal cavity rotating around superior mesenteric artery, SMA. 270 degrees counterclockwise, 90 degrees before the 10th week, remaining 180 degrees in the 10th week when contents retract back into the abdominal cavity. Hindgut, distal third of the transverse colon to the anal canal above the pectinate line. So we have a little diagram as well in my book that's not shown in yours, but it shows the pharyngeal origin, the foregut, the midgut, and then the hindgut. And then the analog for both the it's sort of this very early, like almost like embryonic stage or fetal stage, and comparing that to the into the human body. When we say, for example, the pharyngeal origin, I guess it's not being shown, but the foregut is going to lead to things like the stomach, the esophagus, the liver, and probably the pancreas as well. The midgut leading to things like the small intestine and basically some of like the ascending and parts of the transverse part of the colon. And then the hindgut being basically nothing more than the last third or so of the transverse colon plus everything past that, going up to the rectum. So, make of that what you will. We're going to start talking about ventral wall defects. Again, my understanding is like, okay, there's a pathology section, so you think, well, wouldn't this be in pathology? Well, this is an embryological issue, so they would prefer to keep it in embryology, I suppose. So ventral wall defects and hernias. Ventral wall defects. Developmental defects due to failure of the rostral fold closure, sternal defects, ectopia cordis, lateral fold closure, umbilical gastroschisis, or caudal fold closure, like bladder exstrophy. So there's a little description between, and I think they have it in there as well, with different presentation though, between gastroschisis and comparing that to umbilical. So we have presentation, coverage, and associations. So let's talk about gastroschisis first. So gastroschisis is going to have a paraumbilical herniation of the abdominal contents through the abdominal wall defect. The coverage is not covered by peritoneum or amnion, right-sided paraumbilical. Associations, not commonly associated with chromosomal abnormalities, good prognosis for gastroschisis. It's basically the herniation of this is what it is. It's the paraumbilical herniation of abdominal contents through the abdominal wall defect. That's what it is, gastroschisis. What about umbilical? Umbilical, herniation of abdominal contents through the umbilical ring. So it's a very specific location. It's not the abdominal wall defect. It's an umbilical ring that all this contents are going through. It says your coverage covered by peritoneum and amnion. Light gray, shiny sac, midline, membrane coverage. Okay? For umbilical. Umbilical is very specific. It's going through the umbilical ring, and then therefore it has this peritoneum on it and has this amnion on it. So it has this layer covering it. So what's the association with it, though? Associated with the congenital anomalies, for example, trisomies 13, trisomies 18, Beckwith-Wiedemann syndrome. It's Beckwith as you imagine, Beckwith, Wiedemann as in Wiedemann syndrome, and other structural abnormalities like cardiac, GU, and neural tube. So there are some abnormalities associated with the umbilical, But gastroschisis is a lot more isolated to just having that condition, and has a comparatively, it says here, a good prognosis for gastroschisis. Lymphocele, they're just saying, has a lot of other issues that typically are going to be associated with it we don't really want. Cardiac issues, GU issues, neural tube problems, that kind of stuff. What about congenital umbilical hernia? What about that? Is that covered here? Yeah, right here. It says here, congenital umbilical hernia, delayed umbilical ring to close spontaneously following physiological herniation of midgut, leading to a patent umbilical orifice. Covered by skin, often reducible, protrudes with increased intra-abdominal pressure, like crying, for example, may be associated with congenital disorders like Down syndrome, congenital hypothyroidism as well. Small defects usually close spontaneously. Okay. Now we're going to go to tracheoesophageal anomalies. So, esophageal atresia, EA, with distal tracheoesophageal fistula, TEF, is the most common, 85%, and often presents as a polyhydramnios in utero due to the inability of fetus to swallow amniotic fluid. Neonates drool, choke, and vomit with their first breathing. TEFs, again, tracheoesophageal fistulas, allow excess air to enter the stomach, visible on the chest x-ray as a prominent gastric bubble. Cyanosis is secondary to laryngospasm to avoid reflux-related aspiration. Clinical test, failure to pass nasogastric tube into the stomach, associated with Vater-Vocteral defects. So I don't know what Vater-Vocteral stands for, but VATER and VACTERL defects. In H-type, the fistula resembles the letter H. In pure EA, pure esophageal atresia, the chest x-ray shows a gasless abdomen in the case of a pure esophageal atresia. So see a diagram with a normal esophagus and normal trachea. Okay, fair enough, that's good. Next picture you see pure EA, pure esophageal atresia. You can see right there it's hanging out, and it's just kind of atretic. It's a little kind of how do you describe it? It's just kind of like constricted in an area, you know? It's not letting things pass through it effectively. Then you have a pure TEF type. It's pure tracheoesophageal atresia, which means that it has this little fistula coming off of it, basically. So tracheoesophageal fistula, you have a fistula coming off the side. And then finally, we have EA with distal TEF, which is the most common. The most common being EA with distal TEF. So basically, not only do you have a weird fistula growth thing to the side, it's also just straight up not even connected to the main esophagus. So it's basically, it ends in a blind loop, it looks like, where it doesn't go anywhere. Plus, also, it's the actual lower part of the esophagus below that line is just kind of going off to the side for no reason. Very weird presentation. And so that's what the combination of the two look like. And again, the pure TEF is the H type, but the EA with the TEF is the most common. Both TEF types, may it be a pure TEF or may it be the EA with distal TEF, both of those are going to have prominent gastric bubbles. The pure EA will not have a gastric bubble. And even a normal person, normal anatomy will have a gastric bubble, but let me explain it like this. Normally you will have a gastric bubble, okay? When you have a pure EA, you will have no gastric bubble. It'll be gasless stomach, okay? Because it makes sense, because it's not letting things go through the esophagus. However, when you have, let me see. Let me go. Okay. Let me confirm. I want to make sure I'm not saying anything incorrectly here. But regardless, though, the EA, pure EA, will have a gasless stomach. There'll be no gastric bubble at all. Then what about pure TEF and TEF with EA? When you have a TEF, may it be with the EA or not, you will have a prominent gastric bubble. So again, normally, normal gastric bubble. Pure EA, no gastric bubble. TEF with or without EA, prominent gastric bubble. So just keep that in mind. Because you could see that on a question. You see on the exam, the infant had a gastric bubble, prominent or no, it was gasless, whatever. That tells you immediately what it's going to be, basically, or help you understand what's going on. Now I have another section on here called hypertrophic pyloric stenosis, which you can see on the next page there. It says most common cause of gastric outlet obstruction in infants. palpable olive-shaped mass due to hypertrophy and hyperplasia of pyloric sphincter muscle. In epigastric region, visible peristaltic waves and postprandial non-bilious projectile vomiting at 2 to 6 weeks old. More common in firstborn males associated with exposure to macrolides. Result in hypokalemic, so basically hypokalemic, which is going to be low potassium, and on hypochloremic, so like low chlorine, metabolic, or chloride, I guess you could say, metabolic alkalosis, secondary to vomiting of gastric acid and subsequent volume contraction. So basically you're vomiting out all this acid, so now you have metabolic alkalosis. Ultrasound shows thickened and lengthened pylorus. How do you treat this hypertrophic pyloric stenosis? We have to treat it by giving a surgical incision of the pyloric muscles, or pyloromyotomy. So because basically the hypertrophic pyloric stenosis is this very strong muscle, very heavy muscle that's preventing fluid from getting across from the stomach or into, the more distal parts of the GI tract. And so what do you need to do? You need to basically make a surgical incision to kind of open that up. Make sense? And it can lead to things like metabolic alkalosis because you're vomiting out all your stomach contents, which is where you're making all your acid. So, what about intestinal atresia? Intestinal atresia, my book has a double bubble sign. Your thing has a double bubble sign as well. Mine is a little bit different. It's bigger in mine, but it's a similar idea. You can see the two bubbles right there, right? In picture A. Intestinal atresia. Presents with bilious vomiting and abdominal distension within the first 1 or 2 days of life. Duodenal atresia, failure to recanalize the lumen from solid cord stage. X-ray shows a double bubble, dilated stomach, proximal duodenum, associated with Down syndrome. So remember, the double bubble sign associated with Down syndrome. It's an indication of duodenal atresia. Okay? Jejunal and ileal atresia. Disruption of mesenteric vessels, typically the SMA, leading to ischemic necrosis of the fetal intestine, leading to segmentation, resorption, bowel becomes discontinuous. X-ray may show triple bubble, dilated stomach, duodenum, proximal jejunum, and gastrous colon, associated with cystic fibrosis and gastroschisis. May be caused by maternal tobacco smoke or use of vasoconstrictive drugs like cocaine during pregnancy. Okay. What about the pancreas, spleen, and embryology? So pancreas and spleen embryology. Well, it says here, pancreas and spleen, so pancreas derived from the foregut, ventral pancreatic bud contributes to the uncinate process. Yeah, it is uncinate as in UNC, unc, innate, INATE, uncinate process. Both ventral and dorsal buds contribute to the pancreatic head and main pancreatic duct. We have the annular pancreas and the pancreas divisum. So the annular pancreas, abnormal rotation of the ventral pancreatic bud forms a ring of pancreatic tissue leading to encircles the second part of the duodenum. It may cause duodenal narrowing, which is shown in the picture, I believe, in A, and vomiting associated with Down syndrome. Again, Down syndrome is going to be perhaps a relatively commonly mentioned section in embryology. They have annular pancreas. What do they have? Maybe Down syndrome, possibly. Oh, they have duodenal atresia. What do they have? Maybe Down syndrome, maybe, perhaps, It is going to be a problem that's associated with other kinds of problems, You're adding an entirely additional chromosome, so it's going to lead to some abnormalities, essentially. What about the pancreas divisum? Pancreas divisum, ventral and dorsal parts fail to fuse at 7 weeks of development. Common anomaly, mostly asymptomatic, but may cause chronic abdominal pain and or pancreatitis. Spleen arises in mesentery of the stomach, dorsal mesogastrium, hence mesodermal, but it has a foregut supply, celiac trunk going to splenic artery. And your book has a little diagram for gallbladder, accessory pancreatic duct, etc. Mine likewise, but it's really showing the development, showing ventral pancreatic bud, and eventually its development with the going under the pancreas itself and having a sort of common pathway. So the ventral pancreatic bud basically goes from the right side, transitions over as it shows in your book as well, to the, it's on the, sorry, it should go from the right side to the left side, again, from the perspective of the patient. And then it kind of merges into a singular object, essentially, and develops a sort of, there's a main pancreatic duct, there's going to be main pancreatic duct, okay. And it forms this uncinate process that's kind of bridging between the two for part of it. I don't know what else to really say about it. I mean, it's just kind of showing you how this sort of other additional structure kind of merges onto the rest of the pancreas. And that concludes the embryology section of the GI chapter. I'm going to take a brief break and come back into anatomy. Okay, we're back. Anyway, so now we're on the anatomy section for the GI chapter, talking about retroperitoneal structures. So retroperitoneal structures, shown in the picture A, are posterior to and outside of the peritoneal cavity. Injuries to the retroperitoneal structures can cause blood or gas accumulation in retroperitoneal space. There's a little acronym or a little mnemonic we have here, SAD pucker. It says here suprarenal, adrenal glands, which are not shown, aorta and IVC, duodenum, second through fourth parts, pancreas. And I have a second diagram in my book. That's why it's trying to refer to these things. But just for reference, yours has it too. Okay, pancreas except tail, ureters, which are not shown, colon, descending and ascending, kidneys, esophagus, thoracic portion, which is not shown, and the rectum, partially not shown. So side pucker, which is the stuff that's in the retroperitoneal structure, is going to be suprarenal glands, aorta, duodenum, pancreas, ureters, colon, kidneys, esophagus, and rectum. Okay? Anywho, let's go to the next section. Next page, important gastrointestinal ligaments. Ooh. This could be on the exam. You might have maybe have a few of these potentially. maybe one or two questions. Important gastrointestinal ligaments. You can see all the stuff in that diagram right there. And falciform ligament, etc., etc. Gastrohepatic ligament. But we're going to go through them one by one in this chart as well. You know what? Maybe I should just keep this picture up here for you to see, or maybe you could pause and take a snippet of it or something like that. But I'm going to read a few of these off, and then I'll go continue down the page. So ligament, connects, structures contained, and notes. So falciform ligament connects the liver to the anterior abdominal wall. It contains the ligamentum teres hepatis, which is a derivative of the fetal umbilical vein, and the patent periumbilical veins. It also is a derivative of the ventral mesentery. The hepatoduodenal ligament connects the liver to the duodenum. Fair enough, right? It contains the portal triad, which includes the proper hepatic artery, the portal vein, and the common bile duct. In addition to that, it's a derivative of the ventral mesentery. It is a Pringle maneuver. Ligament is compressed manually or with a vascular clamp in omental foramen to control the bleeding from the hepatic inflow source. Portal vein, hepatic artery versus the outflow, which is the hepatic veins in the IVC. Borders the omental foramen, which connects the greater and lesser sacs and is part of the lesser omentum. Okay, gastrohepatic. Mine thinks is hepatogastric. I don't know if there's, I think it's probably the same thing, I'd assume. But the hepatogastric ligament connects the liver to the lesser curvature of the stomach. Same thing. It is going to contain the gastric vessels, and for additional notes, it's derivative of the ventral mesentery. It separates greater and lesser sacs on the right. It may be cut during surgery to access the lesser sac, and it is part of the lesser omentum. The gastrocolic, which is not shown. Gastrocolic ligament. The gastrocolic ligament connects the greater curvature and the transverse colon. It contains the gastroepiploic arteries, and it is derivative of the dorsal mesentery and part of the greater omentum. The gastroepiploic ligament, or gastrosplenic ligament. I don't know where I got the word epiploic in this context, but next one is the gastrosplenic ligament. Gastrosplenic ligament connects the greater curvature and the spleen. It includes it contains the short gastrix, the left gastroepiploic vessel. That's probably where maybe I just saw that word or something like that. So the gastrosplenic ligament contains the short gastrix and the left gastroepiploic vessels, and it is derived from the dorsal mesentery, and it separates the greater and lesser sacs on the left, and it is part of the greater omentum. The splenorenal ligament. Splenorenal ligament is going to connect the spleen to the left pararenal space. It contains the splenic artery and vein and the tail of the pancreas. And it's derivative of the dorsal mesentery. Then we're going to go off to the digestive tract anatomy. Layers of the gut wall, inside to outside, MS. So layers of the gut wall. Mucosa, epithelium of lamina propria muscularis mucosa. Submucosa includes the submucosal nervous plexus, Meissner's, which also secretes fluid and contains vessels. Muscularis externa, which includes the myenteric nerve plexus, which is Auerbach's plexus, and is also involved in motility. And the serosa, which is when intraperitoneal, and adventitia when it's retroperitoneal. So basically the four layers are mucosa, submucosa, muscularis externa, and serosa, which also can be called adventitia in some contexts. And remember then the submucosa, that's the glandular part, that's where Meissner's complex works. And the musculus externa, that's where the muscular part works, that's where the Auerbach's plexus is at. So Auerbach's plexus for the muscular portion, and the Meissner's complex for the glandular submucosal area. There's also a diagram right there that you can see describing the layers and stuff like that, intestinal villi, submucosal gland, etc., etc. Digestive tract histology. Esophagus, non-keratinized stratified squamous epithelium, upper third striated muscle, middle and lower 2/3 smooth muscle, with some overlap at the transition. Stomach. Gastric glands, A, shown in picture A, which I don't even think your book has. No, it does not. So go back to it. So stomach. Gastric glands, parietal cells are eosinophilic pink, chief cells are basophilic. Duodenum. Villi and microvilli increase absorptive surface. Brunner's glands with bicarbonate secreting cells of the submucosa. Crypts of Lieberkühn, which contain stem cells that replace the enterocytes/goblet cells and Panf cells that secrete defensins, lysozymes, and TNF. And plicae circulares, which is in the distal duodenum. Jejunum, villi, crypts of Lieberkühn, and plicae circularis, taller, more prominent, numerous versus the ileum, leading to a feathered appearance with oral contrast and increased surface area. And the ileum. Villi, pyrus patches, which is shown in a picture in my book but not shown otherwhere. Lymphoid aggregates in lamina propria, submucosa. Plicae circularis in the proximal ileum. Crypts of the Lieberkühn, largest number of goblet cells and cells in small intestine. Okay. Colon. Crypts of Lieberkühn with abundant goblet cells but no villi. So you can kind of tell the difference between the colon, where colon is just, it has goblet cells, lots and lots of goblet cells. It has crypts of Lieberkühn, but there's no real villi. So really, the colon is not so much focused on the sorts of absorptive qualities you would want to have in the small intestine. Small intestine have all the sorts of absorption and that kind of thing, because it wants to have all the sort of surface area and that kind of thing. The colon is focused on trying to make sure there's smooth passage of basically the feces, and to absorb water if necessary. Because you want to make sure you don't have a lot of water loss necessarily. So colon's more focused on making sure you absorb the water and making sure that you can smoothly pass waste, versus the small intestine is more focused on trying to absorb nutrients. So it's a little bit different goal, and so there's going to be differences in the actual histology. It's really funny, though, that they have a histology section in this book, but they don't actually have histology slides showing what they look like, but whatever. Abdominal aorta and branches. So you can see this diagram right here for yourself from T12, L1, L2, L3, L4, L5. I actually don't have that diagram. I have a different diagram. I actually kind of like that diagram. It's very useful. Not necessarily super realistic in how it looks, but that kind of gets you the idea. So arteries supplying the GI structures are single and branched anteriorly. Arteries supplying non-GI structures are paired and branched laterally or posteriorly. Two areas of the colon have dual blood supply from distal arterial branches, watershed areas. These are more susceptible to colonic ischemia, like hypotensive states, and the thromboemboli or atheroemboli. So we were talking about that before with the watershed areas of the brain between the MCA, the PCA, and the ACA. There's watershed areas here as well. There's two areas of the colon that have dual blood supplies that are watershed areas. These places are going to be called the splenic flexure, between the SMA and the IMA, and then the rectosigmoid junction, which is between the IMA branches, last sigmoid arterial branch, and superior rectal artery. And there's a little description about superior mesenteric artery syndrome. You want to read about that as well in this PDF that you can pause and look at. Also says here bifurcation of the abdominal aorta at L4. That's correct. So that's something to be aware of. Celiac is coming off at like T12-ish SMA at L1 and an IMA at L3. Good to know, right? Nutcracker syndrome is what I'm going to go into next. They don't bring that up immediately, but I'll go into it soon. Nutcracker syndrome. That's not fun. Again, I always say, "Oh, this sucks. This is awful. You don't want to have this." It's like, implying that I've personally been through something like that. No, I have not, but I'm sure it's not good to have. Okay, I'm wondering where exactly Nutcracker syndrome is mentioned in this book, because I don't see it. It might not be mentioned. Okay, so it might not be mentioned, so I might just have to call it quits on that. I'll just read it off for you. Let's do it. Okay. Nutcracker syndrome. Compression of the left renal vein because the superior mesenteric artery and aorta. Between the superior mesenteric artery and the aorta. May cause abdominal flank pain, gross hematuria from rupture of the thin-walled renal varicosities, left-sided varicocele. So you have the SMA and the left renal vein dilated. And that's just showing how the SMA is basically compressed. Because basically what happens is this, is that when you have the IVC, the left and right renal veins go to the IVC, but the left renal vein has to cross over the aorta. That's, in theory, not going to be an issue until you realize that the left renal vein is below the SMA. And so when the SMA comes down, it's compressing the left renal vein between the SMA itself and the aorta that's coming off of. And so this is a higher pressure area than the actual left renal vein, and so there's a possibility for compression. What about superior mesenteric artery syndrome? We were talking about that a few minutes ago. So let me go back up to this. Superior mesenteric artery syndrome, characterized by intermittent intestinal obstruction symptoms, primarily postprandial pain when SMA and aorta compress to transverse third portion of the duodenum. Typically occurs in conditions associated with the diminished mesenteric fat, for example, rapid weight loss, low body weight, malnutrition, or gastric bypass surgeries. Interesting. That's an interesting thing. I don't think I've heard of that one before. If I have, I must have forgotten. But okay, sure. Now we're going to go to that graph or that diagram. No, it's a table. We're going to go to the table now. Gastrointestinal blood supply and innervation. So we have the embryonic GU gut region, artery, parasympathetic innervation, vertebral level, and the structure supplied. So foregut, midgut, hindgut. Foregut receives from the celiac artery, gets parasympathetic stuff from the vagus nerve, gets vertebral artery levels T12 to L1, and structures it supplies are the pharynx, vagus nerve only, lower esophagus, celiac artery only, to proximal duodenum, liver, gallbladder, pancreas, spleen, mesoderm. Okay. Midgut gets supplied by the SMA, superior mesenteric artery. Parasympathetics are going to be vagus again. Vertebral level is going to be L1. Okay, sure, L1, sure. And the distal duodenum to proximal 2/3 of the transverse colon is what it concludes. Basically, part of the duodenum going all the way to the 2/3 of the transverse colon. That's the midgut, okay? And what about the hindgut? Hindgut's going to be the inferior mesenteric artery is what it supplies with blood. Parasympathetics are going to be pelvic splanchnic. The vertebral level is going to be L3. And when they say vertebral level, when they say vertebral level, they don't mean like the vertebral level for the sympathetics or something like that. They don't mean the vertebral level for what level the actual guts are on. They're saying this is the actual area where the SMA or the celiac or whatever is coming off of. So celiac artery comes off at T12 to L1. The SMA comes off at L1. The IMA is coming off of L3. So they didn't really explain that very well, but that's what's going on. So for hindgut, the supply is from the distal third of the transverse colon to the upper portion of the anal canal. It says below that, sympathetic innervation arises from the abdominal perivertebral ganglia, celiac, superior mesenteric, and inferior mesenteric. And also, I think for actual innervation, besides the parasympathetic, for normal innervation of the midgut, I think it's T10 to T10 to T11, I believe, and everything below that is like T12 to like I don't even know. And above that's gonna be like T5 through T9. So I think the foregut is like T5 to T9. We're not talking about parasympathetics. We're not talking about parasympathetics. We're talking about like normal innervation. T5 to T9 for foregut, T10 and T11 to midgut, and I think it's like T12 to L1 or L3 or something like that for hindgut. Not including the very far back part of the hindgut, which includes stuff like the S2 and stuff like that. So let me go see. What nerves innervate, or let's say what vertebral levels innervate the hindgut? It's going to say T10L2 and parasympathetics S2 to S4. So basically T10L2 plus S2 to S4. Sure. That's fine. Whatever. What about midgut? Because that seems like it has too much midgut overlap in my opinion. Midgut I thought would be T10, T11. It is T10, T12. Okay. I've heard different things, but that's overall kind of the idea. So just bear that in mind. Now we have a diagram right here, and it's going to be talking about celiac trunk. Celiac trunk, branches of the celiac trunk, common hepatic, splenic, and left gastric. These can constitute the main blood supply of the foregut. Strong anastomoses exist between the left and right gastroepiploics and the left and right gastrics. So we have a celiac trunk right there being shown, common hepatic coming off of it, and the other one coming off of it, I believe, is the splenic. Splenic is going leftward, celiac trunk is going rightward, both coming off of this, common hepatic's coming rightward, obviously going to the liver, and then the celiac trunk's coming off both. There's also this little smaller vessel called the left gastric, and that's supplying the stomach and stuff like that. And going out the esophagus a little bit as well. And it's not a bad graph showing you kind of like not only what vessels are which, but also, well, my book is a little bit better than the book that you see in the PDF, but it'll show you which parts of the stomach are getting what supply from what. Okay. Portosystemic anastomoses. So we have the azygos vein and the esophageal vein, with the inferior vena cava right there as well. I mean, this is just a diagram for you to understand the difference between the systemic venous system that's going on right there and the portal venous system related to the liver right there. You can see with the splenic vein, all that kind of stuff. Paraumbilical vein, portal vein, the inferior mesenteric vein, right? Because bear in mind, a lot of blood is pooling away from, is being collected from that sort of GI tract and being brought back to the liver. So just keep that in mind. You see all that blood going around? It's going to the colon. It's going to the anus. It's going it's around the stomach and the spleen. All that kind of stuff is all pooling back to the portal vein, and it's going to be processed in the liver. Now let me talk about the sites of anastomosis, clinical sign, and the portal versus systemic. So the esophagus. Clinical sign, esophageal varices. So this is what if I have portal hypertension? Let's say, for example, I have portal hypertension. Okay, I maybe have cirrhosis or something, and I'm having portal hypertension now. So my portal system is going to be, hypertensive specifically. What might you see? For the esophagus, you might have esophageal varices. And so if portal versus systemic, left gastric goes to the esophageal veins, which drains into the azygos. So that's the esophageal varices. Left gastric goes to the esophageal. Left gastric to esophageal, drains into the azygos. So that's the portal systemic relationship between those two. The umbilicus. What are you going to have? Caput medusa. It's called caput medusa because it's like the head of Medusa. It has all these little snakes coming around on the abdomen. It looks very interesting. So that's caput medusa for umbilicus. And the portal versus systemic, paraumbilical, which is the portal part. Remember, left gastric is portal. The paraumbilical is portal. And it's going to the, or anastomosing with the small epigastric veins of the systemic system. These are branches of the inferior and superficial epigastric veins of the anterior abdominal wall. And what about rectum? Rectum, if I have portal hypertension, the rectum might show something like an anorectal varices. Anorectal varices. The connection between portal versus systemic is going to be superior rectal, which is the portal, and it's connected to the middle and inferior rectal, which is going to be the systemic. Now, varices of the gut, butt, and caput. Okay, we're really pushing with that one. Gut, butt, and caput, whatever, are commonly seen in portal hypertension. And caput as in caput medusa. Even though I would not like using the whatever. It's there. That's how they use it. That's the mnemonic. You want to use it, you can do that. Knock yourself out. Whatever. So varices of the gut, butt, and caput medusa are commonly seen with portal hypertension. Transjugular intrahepatic portosystemic shunt (TIPS) TIPS treatment creates an anastomosis between the portal vein and the hepatic vein, relieving the portal hypertension by shunting blood to the systemic circulation, bypassing the liver. TIPS can precipitate hepatic encephalopathy due to the decreased clearance of ammonia from shunting. Yeah, so it's not necessarily ideal. You might think to yourself, why, if this is an issue, why would your body even necessarily have this thing in the first place? Why not just have a shunt to begin with, And the answer is because the liver actually has a function, actually has a purpose. And the purpose is to kind of remove toxins from the body. And so if you're actively trying to bypass the liver because there's something wrong with your liver, well, then it can't actually process whatever you're trying to would otherwise bring through the liver. And so as a consequence, you might have ammonia building up in the body, which you don't really want to have. And that can lead to something like hepatic encephalopathy. Again, if you're in a situation where you have portal hypertension, would it be worth it possibly to have something like this intervention happen? That makes sense, yeah. But the reason that there's some consequences of that could be something like excess ammonia leading to an encephalopathy. Just to be aware of that. The things in your body have reasons for them being there, Pectinate line, also called the dentate line, as you see in your PDF. Pectinate line, also called the dentate line, formed where that's funny, I say that and then I look in the book, it says the same thing basically. Pectinate line, also called the dentate line, formed where the endoderm, hindgut, meets the ectoderm. So you have the internal hemorrhoids, abnormal distension of the anal venous plexus, shown in the picture. Risk factors include the older age and chronic constipation. Receive visceral innervation and are therefore not painful. Okay. So the internal hemorrhoids you can't even really feel because they receive visceral innervation. What about external hemorrhoids? A little bit different story. They receive somatic innervation, inferior rectal branch of the pudendal nerve, and are therefore painful if thrombosed. What about anal fissure? Anal fissure, tear in the anoderm between the pectinate line, pain while pooping, blood on the toilet paper, located in the posterior midline between this area and is poorly perfused, associated with low fiber diets and constipation. And you get to see that little diagram right there. Mine has its own diagram, which I think is probably a little bit more detailed, but it has some issues with it, in my opinion. It shows here the pectinate line, and above the pectinate line you have internal hemorrhoids and you have adenocarcinoma, and below the pectinate line you're going to have external hemorrhoids, which are painful, and anal fissures, and also squamous cell carcinoma. Why? Because squamous cell carcinoma is characteristic of the external body, because the squamous cells are what the external body is covered by, so that everything below the pectinate line, i.e. more proximal to the surface of the body, is going to have squamous cells, and therefore squamous cell carcinoma potentially. Everything above that, above the pectinate line, is basically part of the GI system officially, and therefore it's going to have a different kind of histology. And so you're looking to get something like adenocarcinoma. Make sense? And so for above the pectinate line, we have nerves, visceral innervation, inferior hypogastric plexus, T12 to L3. Arteries, again, this is all above pectinate, suprapectinate line stuff. Arteries, superior rectal artery, branch of the IMA. Vein, superior rectal vein, going to the inferior mesenteric vein, going to splenic vein, going to portal vein. And lymphatics, drain to the internal iliac lymph node. What about below the pectinate line? Somatic innervation, pudendal nerve, S2, S4. Inferior rectal artery, branch of the internal pudendal artery, is what's supplying it. For the veins, inferior rectal vein, going to the internal pudendal vein, going to the internal iliac vein, going to the common iliac vein, going to the inferior vena cava. And the lymphatics, drain to the superficial lymphatic lingual, drain to the superficial inguinal lymph node. So again, it's all basically somewhat different, you know. It has its own little thing, because basically below the pectinate line, you're really part of the squamous external body as far as they're concerned. And above the pectinate line, when you're actually in the GI tract, and therefore it has its own system in place. Okay, so let's continue. Liver tissue architecture. The functional unit of the liver is made up of the hexagonally arranged lobules surrounding the central vein, with the portal triads on the edges consisting of a portal vein, hepatic artery, bile ducts, as well as lymphatics. The apical surface of the hepatocytes face bile canaliculi. Basolateral surface faces the sinusoids. Kupffer cells, specialized macrophages, located in the sinusoids, clear bacteria, and damaged or senescent RBCs. Hepatic stellate, IDO, cells in space of discs store vitamin A when quiescent and produce a extracellular matrix when activated, responsible for hepatic fibrosis. Now what about this? Dual blood supply to the liver portal vein, 80%, and hepatic artery, 20%. Zone 1, peripheral zone. Okay. Zone 1, peripheral zone. Affected first by viral hepatitis, best oxygenated, most resistant to circulatory compromise, ingested toxins like cocaine. Zone 2, intermediate zone. Yellow fever. Okay. Zone 3, paracentral, central lobular zone, affected first by the ischemia as least oxygenated, congestive hepatopathy, high concentration of cytochrome P450, most sensitive to the metabolic toxins, for example, ethanol, carbon tetrachloride, rifampin, acetaminophen, site of alcoholic hepatitis. Okay. That's a little diagram right there showing things like the stellate cell. My diagram is a little bit different, but probably the same concept. So basically things that you have Kupffer cells, you have stellate cells, space of discs going on, you have the sinusoids themselves, you have these sorts of cell layers that are kind of going between, that kind of thing. So you have this blood going through, you have blood is providing oxygen, of course, via the branch of the hepatic artery. You have these branches of the portal veins providing you all this blood coming from the GI tract that needs to be filtered, needs to be kind of looked through, so it's not producing, so it's all the toxins are being kind of neutralized essentially, and then eventually they all feed into the central vein, which drains into the hepatic vein, which goes back to, I think, the heart basically. Biliary structures. Cholangiography shows filling defects in gallbladder, blue arrow shown in A, or your book says red arrow. The red arrow shown on the right side, I believe. Well, my picture's different. Okay, whatever. Ignore what I said. Okay, I'm going to read this. Gallstones, filling defects in gallbladder and cystic duct, red arrows in A. Okay. and common bile duct, which is also somewhere over there. Okay, cholangiography shows filling defects in gallbladder and common bile duct. Gallstones that reach the confluence of the common bile duct and pancreatic ducts at the ampulla of Vater can block both the common bile and the pancreatic ducts, double duct sign, causing both cholangitis and pancreatitis respectively. Tumors that arise in the head of the pancreas, usually the ductal adenocarcinoma, can cause obstruction of the common bile duct, leading to enlarged non-tender gallbladder with jaundice. Courvoisier sign. Courvoisier sign. I assume that's how you pronounce it. Let me see. Courvoisier. 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 What is my assumption? You say "voi" because it's VOI, so like "roi." So you don't say when you say in French, "roi," "roi," it's ROI, "roi," and you also have, I guess in this case it'd be "Courvoisier" sign. Do you need to know how you pronounce it? I don't think so. For the exam, no. They're not asking you a French pronunciation check or anything. But I'm just kind of speculating based on what my understanding of the situation is. Cystic duct, gallbladder, liver, common hepatic duct. My picture is basically the same, I think. Common bile duct, accessory pancreatic duct, sphincter of Oddi, which is where the main pancreatic duct is kind of feeding out of, and the accessory pancreatic duct, which feeds out of the other sphincter, which is not mentioned here in the thing, but I think it's called some other kind of thing. The ampulla of Vater, which is kind of the opening area, sort of that rim around, for the passage for things into the sphincter of Oddi. So basically, the sphincter of Oddi along with the ampulla of Vater, and then the thing that's feeding through the sphincter of Oddi, which is the actual main pancreatic duct. You also have the duodenum below. Okay. Anyway, femoral region. Femoral region, organization. Lateral to medial, nerve, artery, vein, lymphatic. You go from lateral to medial to find your navel. Okay. Lateral medial. Okay. That's not too bad. Okay. Nerve, artery, vein, lymphatic, lateral to medial. You go lateral medial to find your navel. Okay, that's an okay one. That's an okay mnemonic. Femoral triangle. Contains femoral nerve, artery, and vein. Venous near the penis. Okay. Whatever, man. Femoral. They kept that one has been that same little turn of phrase has been kept from 2017 all the way to 2025. So they must think that's a real. They've struck gold with that one. Maybe that's their idea behind it. Femoral sheath. Fascial tube 3 to 4 centimeters below the inguinal ligament, contains femoral vein, artery, and canal, deep inguinal lymph nodes, but not femoral nerve. So femoral sheath, adductor longus muscle, the femoral ring site of femoral hernia, lymphatics, femoral vein, femoral artery, femoral nerve, inguinal ligament, and the sartorius muscle. Let's talk about the inguinal canal. And, okay. Inguinal canal. So we have this picture right here. It's just a diagram. My book has the names of the layers, and yours does too. But let me just read it out right here for you. The anterolateral abdominal wall layers, going from the most internal to the most external. Most internal, parietal peritoneum. Then the extraperitoneal tissue. Then the transversalis fascia. Then the transversus abdominis muscle. Then the internal oblique muscle. Then the aponeuroses of the external oblique muscle. What about the spermatic cord layers? Talking about spermatic cord layers here. We have, this is here in the mnemonic, ice tie from bottom up. Okay. So ice tie from bottom up. Internal spermatic fascia, transversalis fascia, going over to the cremasteric muscle and fascia, internal oblique, and then the external spermatic fascia, external oblique. So basically you go from internal spermatic fascia, cremasteric muscle and fascia, and then external spermatic fascia. So that's pretty logical. The external layer is called the external spermatic fascia is external, the internal spermatic fascia is the internal, and between the two is the cremasteric muscle and fascia. And the internal layer is made by the transversalis fascia, the middle layer is made by the internal oblique, and the external layer is made by the external oblique. So it's not too crazy. We have some stuff on hernias. And my book has a little something called myopectineal orifice. So I'll talk about that a little bit here. So let's talk about the inguinal hesabolic triangle right there. It's between the what is that even? I don't even know. There's a look into the hesabolic triangle if I were you. I'll look into that. Okay, so we have the pubic pubic symphysis, we have the evagination of the transversalis fascia. We have the inguinal deep inguinal ring, internal deep inguinal ring. Okay. Anterior superior iliac spine. Sure. It's just giving you a reference point for where this kind of stuff is located. Femoral nerve, external iliac vessels, femoral ring. Okay. What are the inguinal canal contents? Inguinal canal contents are for female, round ligament of the uterus, male, ductus deferens or vas deferens. Okay, so for male and female, you're either going to have the round ligament of the uterus or the vas deferens. In addition to that, in the inguinal canal, you will have the ilioinguinal nerve and the internal spermatic vessels. So the internal spermatic vessels, ilioinguinal nerve, and either the vas deferens or the round ligament of uterus. Okay, what about hernias? Hernias. Those are not fun. Hernias, protrusion of the peritoneum through an opening, usually at a site of weakness. Contents may be at a risk for incarceration, not reducible back into the abdomen/pelvis, and strangulation, ischemia, and necrosis. Complicated hernias can present with tenderness, erythema, and fever. Spigelian hernia, also called spontaneous lateral ventral hernia or hernia of the semilunar line, occurs through defects between the rectus abdominis and the semilunar line in the Spigelian aponeuroses. Most occur in the lower abdomen due to the lack of posterior rectus sheath. Presentation is variable but may include abdominal pain and a palpable lump along the Spigelian fascia. The diagnosis is going to be through ultrasound and CT scan. So that's a Spigelian hernia, which I don't know if they even mentioned in your book. I don't think so. Anyway, we'll continue with hernias briefly. Okay, hernias, continued. Diaphragmatic hernia. Abdominal structures enter the thorax. Bowel sounds may be heard on chest auscultation. Most common causes include, for infants, congenital defect of the pleuroperitoneal membrane leading to a left-sided herniation. Right hemidiaphragm is relatively protected by a liver. Adults, laxity/defect of the phrenoesophageal membrane leading to a hiatal hernia, herniation of stomach through the esophageal hiatus. Sliding hiatal hernia, gastroesophageal junction is displaced upward as gastric cardia slides into the hiatus. Hourglass stomach, most common type, associated with GERD. Paraesophageal hiatal hernia. Gastroesophageal junction is usually normal, but gastric fundus protrudes into the thorax. And so I have a little picture here that I don't think you have in your book, but whatever, showing a herniated gastric cardia with a sliding hiatal hernia, which is going to this one section that's kind of just being pushed above into the diaphragm, and then the other version is a herniated gastric fundus, where like part of it just kind of being herniated to the side, just kind of his own little pouch on the side going out through the diaphragm. And it's called a paraesophageal hiatal hernia. So paraesophageal hiatal hernia, which make its own little side pouch, not going through the esophagus, and the sliding hiatal hernia was what actually has like a little more, so the stomach gets pushed up along with the esophagus up into the diaphragm. What about an indirect hiatal hernia? So indirect inguinal hernia. Now we're talking about inguinal hernia. So indirect inguinal hernia protrudes through the internal deep inguinal ring, external superficial inguinal ring, and into the groin. Enters internal inguinal ring lateral to the inferior epigastric vessels, caused by a failure of the processus vaginalis to close, can form a hydrocele. May be noticed in infants or discovered in adulthood. Much more common in males, as you can see in B. Follows the pathway of testicular descent, covered by all three layers of spermatic fascia. So the way I remember that is when you're trying to test for this, you're having a patient, you're pushing your finger into the area. When you have I'll go into it a little bit. Hopefully they explain. direct inguinal hernia. Protrudes through the inguinal Hesselbach triangle, bulges directly through the parietal peritoneum, medial to the inferior epigastric vessels, but lateral to the rectus abdominis. Goes through the external superficial inguinal ring only. Covered by external spermatic fascia, usually occurs in older males due to the acquired weakness of transversalis fascia. MDs don't lie. Medial to inferior epigastric vessels gives you a direct hernia. Lateral to inferior epigastric vessels gives you an indirect hernia. Now bear in mind with this one that when you put your finger in the area trying to figure if it's direct or indirect, if you can feel it directly on your finger, it's actually an indirect hernia. If you feel it to the side of your finger, it's actually a direct hernia. So it's a little bit counterintuitive when you're trying to feel for it. But when they talk about a question where you're putting your finger in that area, if it's directly on the finger, it's an indirect. If it's on the side of your finger, it's a direct. When you're putting your finger into that ring, into that inguinal ring, it's a counterintuitive clinical presentation. Because you would think it would be, the direct one's going to be felt right on your finger, directly on your finger when you put it into the ring, right? Into the into this, what do you call it? Into the inguinal canal. You put your finger to the inguinal canal, you're going to have them bear down. If you feel it directly on your finger, indirect hernia. If it's feel it to your side of your finger, direct hernia. It's counterintuitive, but that's how it is. And I would look into that if I were you. I might be getting something wrong, possibly. I don't know. I think I'm correct, of course, but can't say for 100%. Just for disclosure. Femoral hernia protrudes below the inguinal ligament through the femoral canal, below and lateral to the pubic tubercle. More common in females, but overall inguinal hernias are the most common. More likely to present with incarceration or strangulation versus the inguinal hernia. Okay. And this is a good explanation here, by the way, for the Hesselbach triangle. So inguinal or Hesselbach triangle, inferior epigastric vessels, lateral border of the rectus abdominis, and the inguinal ligament. Just be aware of that. Now we will be going to the third section, which is the last section I'll be covering today, the gastrointestinal chapter, which would be the physiology section. And I'll be taking a brief break and coming back to you soon. Okay. So gastrointestinal physiology. Gastrointestinal regulatory substances. Gastrin. We're going to talk about regulatory substance, source, action, regulation, and notes. Gastrin. The source is G cells. Antrum of the stomach, duodenum. What does it do? It elevates the gastric proton secretion, the H plus secretion, increases the growth of gastric mucosa, increases gastric motility. When it regulates, what's a regulation? Increased by stomach distension / alkalinization, amino acids, peptides, vagal stimulation via the gastrin-releasing peptide, GRP. That's what upregulates it. All this stuff upregulates it. What downregulates it? What kind of limits it? It's downregulated by pH less than 1.5. So if it's already super acidic, it's going to downregulate GRP. Downregulate gastrin. Notes: it's going to increase by chronic PPI use. It's going to increase in chronic atrophic gastritis, like H. pylori. It's going to rapidly increase in Zollinger-Ellison syndrome because of gastronoma. Okay, let me go back into it. So here's the thing with gastrin. When I'm talking about regulation and notes, when they have a little up arrow, it's up regulation. It's trying to elevate it. When you talk about the little down arrow that's down regulating, it's trying to minimize it, right? And when it talks about why would PPI use increase your gastrin, it's trying to compensate. When you're forcing your body to have an elevated stomach pH, you're saying we want to have the pH increase in the stomach. It's going to be more basic. Your body's going to say, oh, this is way, way too basic for us. We want to go increase the acid content. And so what is it going to do? It's going to release more gastrin. Right? When your body, for example, here's another example for you. Kind of unrelated, but when you are, for example, taking a lot of caffeine or other kinds of stimulants, your body's going to say, oh, this is too much. We're going to try to keep it down low. And so as a consequence, you will actually need to take more and more and more stimulants in order to kind of keep the same sort of, perhaps high, as you could say, as you did before, because now your body's trying to compensate for it. And when you stop taking it, you're going to crash. When you stop taking for whatever stimulant that might be like caffeine, you're going to get a really big headache because now your body is already compensated for the caffeine intake, the stimulant use, and so it's trying to compensate. For your thyroid, for example, if you're in a very cold environment, your body's cold all the time, your body will probably increase its TSH and therefore increase your the T3 and T4 levels, because your body produces more heat when you have more T3 and T4. So it's a compensation mechanism. But if I would assume the opposite is the case. If you have a very, very hot temperature, very hot environment, you might not produce as much thyroid hormone, presumably. But your body is always trying to compensate and maintain homeostasis. And so if you're really taking PPIs to kind of shift the balance towards a more basic stomach lining, you're going to encourage more gastrin to be produced to counteract it. Make sense? Think about that when you take test questions. What kinds of things is the body going to do to compensate for modifications or diseases? What about ghrelin? Is ghrelin mentioned here? Ghrelin's in my book. I don't know if it's mentioned here. Ghrelin, down here. I'll talk about ghrelin. Ghrelin. Its source is the stomach. Its action is going to increase appetite. This is ghrelin stomach. I always remember it as ghrelin goblin. It's kind of, again, a lot of my little memory terms. I make fun of these people for making goofy things like whatever. What did they say? Was it 2 pages ago? They said something like Venus near the penis. Okay, like what are we doing here, man? But for ghrelin, I say ghrelin goblins. I don't know, are ravenous, perhaps gluttonous. So, and I also think of leptin lemur. I don't know why leptin, because lemurs are like eating plants. Probably that's not even technically. I don't think it's even necessarily true. But I guess they're like to me they're lean. So leptin, lean, lemur, satiation, ghrelin, goblin, gluttonous, ravenous. So ghrelin encourages you to have a bigger appetite, just for reference. So ghrelin causes you to have a bigger appetite. Regulation, it's upregulated in fasting state. Why? Because it wants you to eat food, right? And it's downregulated by food, i.e., you start releasing ghrelin when you are being satisfied. In notes, it's going to increase in Prader-Willi syndrome. Now, Prader-Willi syndrome has other issues as well. You have like a cognitive deficit, I think, as well, Prader-Willi syndrome. But you also have a lot of ghrelin excess, and so you get really fat because you're constantly hungry. You also have a decreased ghrelin level when you have after a gastric bypass surgery, so you will lose weight, and I guess in part because of that, at least. Because you're not as hungry. Somatostatin. We'll go back up. Somatostatin. The name should give it away. Somato, body, statin. Think about well, now I'm thinking about somatomedin, now I'm thinking about this kind of stuff. But it's kind of trying to halt growth hormone, right? Am I mistaken in saying that? Somatostatin is trying to halt growth hormone? Sorry, this is a bad. Does somatostatin inhibit growth hormone? Yes. Okay. If growth hormone is like somatotropin, right? It's promoting growth of the body. Somatostatin is going to kind of counteract that effect. But somatostatin, let me just read it out. Where is it made? D cells in the pancreatic islets and GI mucosa. And I say D cells in here, I would say it's delta cells, not D cells. Where is somatostatin produced? It says the GI tract. Okay, but where specifically though? Delta cells. Do they not know how to put the delta letter in here? Are they just like not able to do that for some reason? They're delta cells. There's beta cells, alpha cells, and delta cells. And the delta cells are the word that somatostatin is made in the pancreatic islets. It's also in the GI mucosa. Action of somatostatin. It decreases gastric acid and pepsinogen secretion. It decreases pancreatic and small intestine fluid secretion. It decreases gallbladder contraction, and it decreases insulin and glucagon release. So it's basically inhibitory in many ways. So what about regulation? Well, somatostatin is upregulated by acid, and it's downregulated by vagal stimulation. Makes sense? Basically, again, the body's trying to maintain homeostasis. If your body's getting too acidic, it's going to say, hey, somatostatin's going to help us kind of cool that down, kind of wind that down a bit so it's not too crazy. Notes for somatostatin, it inhibits the secretion of various hormones, encourages somatostasis. Okay. Octreotide is an analog used to treat acromegaly. True, because acromegaly is a consequence of growth hormone excess. Carcinoid syndrome, VIPoma, and variceal bleeding. True. What about cholecystokinin? Cholecystokinin is produced in the eye cells, duodenum and jejunum. They're going to increase pancreatic secretion, increase gallbladder contraction, decrease gastric emptying, and increase the sphincter of OD relaxation. Its regulation includes upregulation by fatty acids and amino acids. Make sense? Because the whole point of the cholecystokinin, remember, think about the root word for this, cholecystokinin. Cholecyst refers to the gallbladder. Cholecyst is a big, it's a name for it. They call it cholecyst, okay? And kinin means movement, so it's encouraging the movement or the action of the gallbladder, i.e., the secretion of gallbladder. The gallbladder is going to contract and empty its contents into the duodenum. Make sense? So cholecystokinin acts on neuromuscarinic pathways to cause pancreatic secretion. It does have pancreatic effects, but the reason it's called cholecystokinin is because it also has gallbladder effects. What about secretin? Name should give it away. Made by S cells in the duodenum. It elevates pancreatic bicarbonate secretion, right? It's encouraging bicarb secretion, because it's called secretin, decreases gastric acid secretion, increases bile secretion. Secretin is going to be upregulated by acid, fatty acids, and lumen of duodenum, and also it increases bicarbonate and neutralizes gastric acid in duodenum, allowing pancreatic enzymes to function. Glucose-dependent insulinotropic peptides. K cells, duodenum and jejunum. What does it do? Well, exocrine, it decreases the gastric proton secretion, and in endocrine, it increases the insulin release. It's upregulated by fatty acids, amino acids, and oral glucose, also called gastric inhibitory peptide. That's what I've heard of it as. It's a glucose-dependent insulinotropic peptide. Well, that's a mouthful. Why don't you just call it GIP? Why don't you just call it GIP, right? So GIP, gastric inhibitory peptide, is also called glucose-dependent insulinotropic peptide, but its oral glucose load increases insulin compared to IV equivalent due to the GIP secretion. Okay, that's interesting. Okay. What about Motilin? What does Motilin do? Think about Motilin, movement, motile. What do you think it does? Motilin, released from the small intestine, produces migrating motor complexes, MMCs. It increases in fasting, so it's going to be upregulated in fasting state. And motilin receptor agonists like erythromycin are used to stimulate intestinal peristalsis. Vasoactive intestinal polypeptide. Parasympathetic ganglia in the sphincters, gallbladder, and small intestine. Action includes increasing intestinal water and electrolyte secretion, increasing relaxation of the intestinal smooth muscle and sphincters, and decreasing gastric acid secretion. It is going to be upregulated by distension and vagal stimulation, and decreased by adrenergic input. And notes include VIPoma, which is a non-alpha, non-beta islet cell pancreatic tumor that secretes VIP, again that's that vasoactive intestinal polypeptide, associated with watery diarrhea, hypokalemia, and achloridria. So WDHA syndrome. I don't know. That's what that's called. That's what it's called. Watery diarrhea, hypokalemia, achloridria. And remember, you could treat VIPoma with what? Octreotide, which is an analog of what? Somatostatin. Nitric oxide. Let's talk about it. Whereas it made doesn't say. It says here it upregulates smooth muscle relaxation, including lower esophageal sphincter. Notes: loss of nitric oxide secretion is implicated in the increase in lower esophageal sphincter tone of achalasia. Okay. Gastrointestinal secretory products. So I'm going to start off with what my book says. My book says gastric acid. So gastric acid, source, action, regulation, notes. So gastric acid originates from the parietal cells of the stomach, which I don't know if there's a picture diagram for yours. Yours is a little bit different diagram, I think. Yeah, it looks different. So gastric acid is produced by the parietal cells of the stomach. It decreases the stomach pH. Why? Because it releases produces protons, right? And it's going to be regulated by a few different things we're going to go to in a little bit here with the intrinsic factor as well. And notes are going to be common as well. So what about intrinsic factor? Intrinsic factor is also made by the parietal cells of the stomach. What does intrinsic factor do? Well, vitamin B12 binding protein required for B12 uptake in terminal ileum. So basically, intrinsic factor from the parietal cells is necessary to actually absorb B12 effectively. If you do not have functioning intrinsic factor, you will not be able to absorb B12, which is a big issue because that will cause issues with your central nervous system because it will lead to SCD and I think like basically demyelination, stuff like that. It will also lead to megaloblastic anemia. So basically a kind of a kind of megaloblastic anemia, sort of macrocytic anemia. So you don't want that to you don't want that to happen, okay? So how is gastric acid and intrinsic factor, how are they regulated? Well, they're upregulated by histamine, vagal stimulation, which is through acetylcholine, and gastrin. They are downregulated by somatostatin, GIP, prostaglandins, and secretin. And some notes: Autoimmune destruction of parietal cells, which are pink eosinophilic in histology, leads to the chronic gastritis and pernicious anemia. Again, why? Because of the fact that if you have a lack of B12 because you can't absorb it because you have no intrinsic factor to help you absorb it, which is being done, again, that's actually happening in the terminal ileum. You think it's in the stomach, but it's not. It's being done in the terminal ileum. It's just it passes through the stomach first and allows you to actually bind to it using the intrinsic factor made in the stomach. But if you can't do that, well, then you're going to have subcombined acute, is that SCD? Actually, I'm not saying that incorrectly. SCD, subacute combined degeneration. So I was saying that incorrectly. I was saying subcombined acute degeneration. It's actually subacute combined degeneration, SCD. That makes more sense. So you don't want that to happen. And you also do not want to have pernicious anemia, which is because you have a B12 deficiency. Which is also megaloblastic, it's macrocytic, okay? What about pepsin? Pepsin is from the chief cells of the stomach. It does protein digestion, right? And, really, it's originally pepsinogen, and then it becomes pepsin. It does protein digestion. It's upregulated by vagal stimulation, acetylcholine, and local acid. And notes, pepsinogen inactive is then converted into pepsin active in the presence of hydrogen ions, i.e. protons, which you will have some of those in the stomach because you're producing them from the parietal cells. What about bicarbonate? Bicarbonate is made in the mucosal cells of the stomach, duodenum, salivary glands, pancreas, and the Brunner's glands of the duodenum. Action is neutralizes the acid. It's upregulated by pancreatic and biliary secretion with secretin. And the notes, trapped in the mucus that covers the gastric epithelium. I have a little graph in mine. I have a little diagram, and you have a little diagram in here as well. It's a little bit different, though. But that's just going to help you figure out, what's going on between these different hormones. You have mucus cells, D cells, I cells, S cells, K cells, parietal cells, chief cells, ECL cells, all that fun stuff. Maybe I think D cells might just be the stomach type for somatostatin. Let me see something quickly. I know that, what do D cells secrete? Okay, so I'm just kind of making a mistake here. So I know that delta cells in the pancreas produce somatostatin, but apparently D cells, which are a different thing, also produce somatostatin, and presumably in the stomach. So I guess they both produce somatostatin, just at different places. It says here in your book, mine doesn't say this, but gastrin elevates acid secretion primarily through its effects on the enterochromaffin-like cells, ECL cells, leading to histamine release, rather than through its direct effect on parietal cells. Yeah, parietal cells have multiple ways to actually encourage its action of its proton pumps. It has both effects from histamine and an effects through histamine and effects through gastrin, and I think it's something else as well. It's different things are acting on the actual cells, but it is true that gastrin both acts directly and indirectly, and the indirect effect is stronger. My book has the same picture right here on the next page on 380. It says here, locations of gastrointestinal secretory cells. Gastrin increases the acid secretion primarily through its effects on the enterochromaffin-like cells, ECL cells, leading to a histamine release rather than through its direct effect on parietal cells. And there's a diagram that's not all that different from the diagram that you have in your book. But it goes all the way over to the pancreas and stuff like that, showing the CCK and the CCK1 receptor and that kind of stuff, amylase, lipase, and so forth. And now we're going to go into that a little bit with this section, talking about pancreatic secretions. And we're on 380 right now. We'll wrap up on 382. Pancreatic secretions. Isotonic fluid. Low fluid leads to a high chloride. High flow leads to a high bicarb. We have enzyme, role, and notes. Alpha amylase. It's used for starch digestion and is secreted in its active form. Lipases are used for lipid digestion or fat digestion. Proteases are used for protein digestion, as you can imagine, right? Lipases, lipid digestion. Proteases, protein digestion. Amylase, alpha amylase, starch digestion. So proteases include trypsin. Chymotrypsin, elastase, and carboxypeptidases. They are secreted as proenzymes, also called zymogens. Dipeptides and tripeptides are degraded within intestinal mucosa via the intracellular process. Trypsinogen, converted to the active enzyme trypsin, leading to an activation of the other proenzymes and cleaving of the additional trypsinogen molecules into active trypsin, positive feedback loop. Converted to trypsin by the enterokinase/enteropeptidase, a brush border enzyme on the duodenal and jejunal mucosa. Carbohydrate absorption. So only monosaccharides, glucose, galactose, fructose, are absorbed by the enterocytes. Glucose and galactose are taken up by the SGLT1, sodium dependent, and the fructose is taken up by the facilitated diffusion of GLUT5. All are transported to the blood via GLUT2. D-xylose test, I think D in this context means like a dextro. Yeah, dextro-xylose test, like dextro as in like that's how the orientation molecularly is right rather than levo, which is left. So D-xylose test, simple sugar that is passively absorbed in the proximal small intestine. Blood and urine levels are decreased with mucosal damage, normal in pancreatic insufficiency. What about vitamin and mineral absorption? Vitamin and minerals absorption. Vitamin and mineral deficiencies may develop in patients with small bowel disease, bowel resection, intestinal failure, also called short bowel syndrome, or bariatric surgery. For example, vitamin B12 deficiency complicating terminal ileum resection requires supplementation. Iron absorbed as Fe2+ in duodenum. Folates absorbed in duodenum and jejunum. Vitamin B12 absorbed in the terminal ileum along with bile salts requires intrinsic factor. Iron first, bro. Okay, this is a mnemonic. Iron fist, bro. Okay, so iron, folate, bro. I don't know. What kind of mnemonics are these? Iron. Is that like a common phrase people say? Oh, I always say iron fist, bro. I never said that in my life until now, apparently. So iron is first, then the folates, and then the B12. Okay. Dumping syndrome. Hyperosmolar food, often sugary, moves too quickly from the stomach to the small intestine, typically occurs after stomach or esophageal surgery. Typically occurs after stomach or esophageal surgery. So that's dumping syndrome. Because the sugary food, the hyperosmolar food, which may be sugary oftentimes, moves too quickly through the stomach and small intestine. What about Peyer's patches? What about that? Well, Peyer's patches, unencapsulated lymphoid tissue, which is shown in the picture A, found in lamina propria and submucosa of ileum, contain specialized microfold M cells and sample and present antigens to the immune cells. B cells, stimulated in germinal center of Peyer's patches, differentiate into the IgA secreting plasma cells, which ultimately reside in lamina propria. IgA receives protective secretory component and is then transported across the epithelium to the gut to deal with the intraluminal antigen. And this is the memory device here. I'm going to call this memory devices now. Maybe mnemonic might not be the appropriate way to phrase it. Memory device. Think of IgA, the intragut antibody. Sure. I remember it as like, okay, IgA, it's in the mucosal tracts. IgE is for parasites and allergies. So that's what I just remember which one does which, that kind of thing. But whatever, IgA is going to be the ones you use in the mucosal system, mucosa, including the GI tract. What about bile? Bile. Composed of bile salts, bile acids conjugated to glycine or taurine, making them water-soluble. phospholipids, cholesterol, bilirubin, water, and ions. Cholesterol 7-alpha hydroxylase catalyzes rate-limiting step of bile acid synthesis. The functions: digestion and absorption of lipids and fat-soluble vitamins, bilirubin and cholesterol excretion, the body's primary means of elimination, antimicrobial activity via the membrane disruption. Also, decreased absorption of enteric bile salts at distal ileum, as in short bowel syndrome, Crohn's disease, prevents normal fat absorption and may cause bile acid diarrhea. Calcium, which normally binds oxalate, binds fat instead, so free oxalate is absorbed by the gut, leading to an increase in frequency of calcium oxalate kidney stones. Okay. Bilirubin. Heme is metabolized by the heme oxygenase to biliverdin, green, which is subsequently reduced to the bilirubin, yellow-brown. Unconjugated bilirubin is removed from the body by liver, conjugated with glucuronate, and excreted in the bile. Direct bilirubin, conjugated with glucuronic acid, water-soluble, dissolves in water. Well, no kidding. Okay. Indirect bilirubin, unconjugated, water-insoluble. Okay, so when it says so basically what they're saying is direct bilirubin dissolves in water, indirect is insoluble in water. Okay, fair enough. There's a little diagram for you as well showing RBCs to heme into unconjugated bilirubin. The unconjugated bilirubin is going to combine with albumin to give you unconjugated bilirubin albumin complex, and that'll become by the UDP glucuronyl transferase becomes conjugated bilirubin, which is very important. That's going on in the liver. And the conjugated bilirubin is going to become urobilinogen. And most of that's going to be excreted in the feces as stercobilin, which is brown color stool. The other 20% is going to go over somewhere else. 10% is going to go in the kidney and then be excreted in the urine as urobilinogen, which is giving the yellow color of the urine. And the other 90% of that 20% is going to go into the liver for enterohepatic circulation. Okay. So again, it's all a consequence of RBC hemolysis back into heme, and that most of it's going to be brought as stercobilin in the feces, but some of it's going to be brought into the urine or brought back to the liver. Now, along with that, remember that the direct bilirubin does dissolve in water, but the indirect, which is what comes before, is not soluble and is the unconjugated form. So unconjugated indirect is insoluble. Conjugated direct, which comes later, is now soluble and now can be removed from the body. And that will conclude, I believe, our section for today. I want to see how long I've been going. I mean, I've been going on for about an hour and 38 minutes. It actually doesn't feel that crazy to me at this point. To be fair, I was taking a few minor breaks here and there. It wasn't too wild. But, the other end of this, basically this was not a particularly long video today. I figured it's going to be because this is like a 45-page-ish chapter, I believe. So I was figuring, well, maybe a little bit more than that. It's like, well, it is like 20, it might be 23 or 24 pages per day between the two different sections, perhaps. And, I was thinking it was going to be like, oh, maybe this section would be like 2 or 3 hours. The other one would be 2 to 3 hours. This one's only like an hour and 38 because there's a lot more pictures in this one. There's not as much. It's not as wordy as some of these other chapters might be. A little bit more dense, right? This one's not too bad. However, I still don't really want to spend another 2 hours working on this per se, and I think it's probably going to be a little bit longer in the back end. Oh, I don't know. I can't say for sure. However, I would rather just wrap it up for today and maybe come back to it tomorrow. So if you listen to this, hopefully it was of good use to you. I hope you have a wonderful rest of your day. Thank you, and bye.